Hello, hello, sound check, sound check. Hello.
Ma'am, we are live now. We can start.
Dr. Safalta.
Good evening, everyone. So, as a group from the Focus Studies in Breast Cancer, I would like to invite you all up in a comprehensive master course in breast cancer. And this is our fourth webinar in which we'll be focusing mainly on the pathology. So, when we talk about pathology, we would like to talk about our beloved Dr. Anita Borges. I would like to invite Dr. Arun Goyal, who is chairman of Andromeda Hospital, and request him to throw light about this webinar as well as on Dr. Anita Borges, his experience with her.
Thank you, Dr. Safalta. Um, First of all, it's my honor and privilege to welcome all the faculty and all the people who are attending the webinar. As Dr. Safalta mentioned, this is the fourth webinar of this series of master course or master class in breast cancer. So I think many of you would be aware that we have been doing this webinar series overall focus studies in breast cancer from the very beginning of COVID. We started somewhere in June of 2020 and had done nearly 35 webinars prior to this master course. And the objective of planning this master class was to sort of start from the beginning and go covering all the issues related to breast cancer and breast diseases. So we have had one on anatomy and two on imaging, and with the excellent faculty that we are able to organize in these webinars, we are all sort of get illuminating talks and wonderful discussions. And the same is expected today also. And now coming to this sad part that recently we lost Dr. Anita Borges. I would like to clarify with all of you and Dr. Safalta also that I have not had the opportunity to work with her directly because she was in Bombay and primarily originally associated with Tata. So, coming to the details, she was born in 1947, basically the year India became independent, and we lost her on 18th of September. She, as has been mentioned in the slide, was recognized or known as the queen of histopathology. And that is something which I can really vouch for. But before that, let's go through the details that she basically studied from Tata, Bombay only, BYL Nair Hospital and the Topiwala National Medical College, where she did her graduation as well as post graduation. But later on, she went to Royal Marsden and Memorial Sloan Kettering Centers for advanced exposure in oncopathology. And I must say that MSK and Royal Marsden are two of the leading oncology facilities globally. And after this, she was basic working in Tata Memorial Hospital. And as Dr. Rajiv Agarwal told me recently, who had worked in Tata Memorial Hospital previously, that Dr. Borges' father was a surgeon and a very fine surgeon at Tata Memorial Hospital. And she followed in his footsteps and worked in the pathology department there, where she was became the head and later retired. After that, she established oncopathology pathology services in SL Raheja Hospital. What I remember for last nearly 20-25 years is that whenever had heard her in some conferences where beautiful talks were delivered, and whenever people were stuck in a diagnosis, the person they would think of wherever they were in the country was Dr. Anita Borges. So we would send the sample, and after 8 to 10 days, and generally our doubts would be resolved. So it is a huge loss to the oncology community overall, but I would say that she has passed her knowledge, learning, and skills to a lot of people who are doing great work in pathology. And I would just request Dr. Rajiv to add something from his personal experience, and then we can start the webinar.
When I was doing my fellowship, I remember one incident that once we took a breast specimen for a frozen section, and that day she was on duty at the frozen section, and she just cut the specimen and said, "Go ahead and start the surgery. I will report the frozen, but this is malignancy." So even at that young age of, I'm talking of 1985, she was that confident pathologist that just on the grossing she was 101% sure that this is a malignancy and go ahead. And not only that, second thing which I was telling Arun, that her father was one of the finest surgeon of the century, people say, and the road that Tata Memorial Hospital stands today is called in the name of her father, Dr. Ernest Borges Marg in Parel. Over to Arun.
That is all from my side, and I would hand over to Dr. Falta and Dr. Prekshi to take it forward.
So, yes, Dr. Anita Borges, what we lost. Even just yesterday, we were having a very difficult tumor, a patient who is having CA breast, who has a past history of CA breast into 17 years back. Now she presented with a GB mass with lung mets and bone mets. And when we did the biopsy, it was looking like liver infiltration. And when the biopsy was done, we thought of that it will come out to be CAGB, but it was a CA breast. And then there were multiple markers which were looking like HCC, few markers of CAGB, and few markers of breast. All were coming positive, and we were like, uh, काश डॉक्टर अनीता होती तो अभी ये प्रॉब्लम सॉल्व हो जाती. So, so we now come to our next section, that is uh, basics of pathology, breast pathology. And the speaker will be Dr. Garima Durga, and she is Senior Consultant, Department of Pathology, RGCI, Delhi. Welcome, Dr. Garima.
So Dr. Garima is not going to be present today. She had some urgent work and she was kind enough to record her presentation and share with us. So Sunidhi is going to run her presentation.
I'm Dr. Garima Durga. I'm a histopathologist at Rajiv Gandhi Cancer Institute and Research Center, Delhi. Today I'm going to take you through the basics in breast cancer pathology. As we all know, histology is the gold standard of diagnosing breast cancers. Despite the insights into the molecular and genetic backgrounds available to us, histology remains the basis of the classification even today. It is important to recognize the histological type and grade for proper classification and prognostication. This is the present classification of epithelial tumors of the breast from the WHO 5th edition book of breast tumors. For today, we are going to focus on the malignant epithelial tumors of the breast, which can be in situ tumors or invasive tumors. To start with, first we have ductal carcinoma in situ. This is the non-invasive proliferation of cohesive neoplastic epithelial cells confined to the mammary ductal lobular system, exhibiting a range of architectural patterns and nuclear grades. So in simple terms, in this, the neoplastic proliferation is limited to the duct lumen by a peripheral layer of myoepithelial cells. So when this layer is breached and the tumor cells enter the stroma, it is called as invasive carcinoma. It can be microinvasive or frankly invasive. The risk factors of DCIS are similar to those of invasive tumors. It is a precursor of invasive breast carcinoma and low and high grade DCIS showed different rates of progression to IBC. These are the 5 architectural patterns of DCIS: solid type, papillary type, micropapillary, cribriform, and comedo type. And to highlight the myoepithelial cells at the periphery, we can use a variety of immunostains like SMMH, CK56, or P63. On the basis of cytology, DCIS can be categorized into low grade, intermediate, or high grade. In low grade tumors, we have small monomorphic cells with uniform nuclei and uncommon mitosis or necrosis. Whereas in high grade DCIS, we have large atypical cells with high mitosis. Necrosis is also common. Tumors showing features intermediate between these two categories are categorized as intermediate grade DCIS. So this is a picture of low grade cribriform DCIS showing sieve-like pattern and low grade nuclear features. This picture on the right shows micropapillary low grade DCIS with a focus of microcalcification. This is high grade solid DCIS, and this picture on the right shows high grade DCIS with central comedonecrosis. Then we have intermediate grade cribriform DCIS, and this picture shows mixed DCIS composed of low grade on the left, low grade on the right side, and high grade on the left side. The histological report of DCIS should include the architectural pattern, nuclear grade, presence or absence of necrosis, size of the lesion, distance to margins, and presence or absence of microcalcification. Next, we have lobular carcinoma in situ. This is again a non-invasive neoplastic proliferation of disc cohesive cells originating in the terminal duct lobular units, which may or may not involve the terminal ducts. So they show characteristic loss of E-cadherin expression. In this microphotograph, we can see the arrows highlight the cells of the LCIS, which are negative for E-cadherin, whereas arrowheads show the benign ductal epithelium, which shows retained E-cadherin membranous expression. The risk factors of LCIS are similar to those of DCIS. In approximately 81% of these tumors, there is inactivation of the CDH1 gene, which leads to loss or impaired function of E-cadherin. E-cadherin is responsible for cell-to-cell adhesion and maintenance of lobular architecture. So when this is defective, it leads to loss of cell-to-cell adhesion, increased cell proliferation, and altered organization of the lobules, giving rise to characteristic appearance of lobular neoplasia. This is a risk factor for and a non-obligate precursor of invasive breast carcinoma. The relative risk of subsequent breast carcinoma in these patients is 8 to 10 times the risk in the general population. These are the different patterns of LCIS. First is the classic LCIS composed of small disc cohesive cells. Mitosis and necrosis is rare. Then we have pleomorphic LCIS composed of large disc cohesive cells with nuclear pleomorphism equivalent to cells seen in high-grade DCIS. Comedonecrosis is commonly seen. Then we have florid LCIS, in which the cells show similar histology as that of classic LCIS, but they form a confluent mass-like architecture because of little or no intervening stroma between the distended acini. In this also comedonecrosis and calcification is common. Then comes the category of invasive breast carcinoma special types. Now these are special types because they show a particular histology in more than 90% of the tumor area. If it is between 10 to 90%, it is called a mixed carcinoma. And if it is less than 10%, then it is called as IBC NST with focal area of special type. These special types include tubular carcinoma, cribriform carcinoma, mucinous carcinoma, mucinous cystadenocarcinoma, invasive micropapillary carcinoma, carcinoma with apocrine differentiation, and metaplastic carcinoma. We are going to talk about each one of them now. So first is tubular carcinoma, which is a low-grade invasive breast carcinoma composed of well-formed tubules with open lumina. This is the hyper view of the same. It is generally seen in older patients. They tend to be small sized, most are detected incidentally, and by definition, they are grade 1. So, if you see substantial cytological atypia or high mitosis, it excludes the diagnosis of tubular carcinoma. They are diffusely and strongly ERPR positive, HER2 negative with an excellent long-term outcome. 5-year survival rate is 88%. Then we have cribriform carcinoma, which is again a low-grade invasive carcinoma composed of well-defined cribriform sieve-like spaces. This is also ER positive and HER2 negative with a favorable outcome. 10-year overall survival rate is 90 to 100%. Then next we have mucinous carcinomas. These invasive tumors show clusters of epithelial tumor cells suspended in pools of extracellular mucin. So these can be type A, which is the hypocellular type, and type B, which is the hypercellular type, with large sheets or clumps of malignant epithelial cells suspended in extracellular mucin. There is no prognostic difference between type A and type B mucinous carcinoma. So these are generally low or intermediate grade. Usually ERPR positive, HER2 negative. HER2 is rarely positive in about 10% of mucinous carcinomas with micropapillary pattern. These tumors with micropapillary pattern are seen in younger age and associated with more frequent lymphovascular invasion and lymph node metastasis. There is also this mucinous carcinoma with signet ring cell differentiation, which must be distinguished from metastasis to the breast. Next, we have invasive micropapillary carcinoma, which is composed of small, hollow, or morula-like clusters, which are surrounded by clear spaces. These are intermediate or high nuclear grade tumors, ERPR positive, HER2 is variable. They are associated with more frequent lymphovascular invasion and axillary lymph node involvement, leading to worse prognosis. On immunostaining, EMA shows a reverse polarity, that is, it is positive in the apical portion of the cells and not the luminal portion. Then we have carcinoma with apocrine differentiation. In this, we have large cells with abundant eosinophilic granular cytoplasm and round vesicular nuclei with prominent nucleoli. These are also intermediate or high nuclear grade tumors, which are ERPR negative, and HER2 new positivity is seen in 30 to 60% of these cases. Then we have metaplastic carcinomas. This is a heterogeneous group characterized by differentiation of the neoplastic epithelium towards squamous cells and or mesenchymal looking elements, which can be spindle, chondroid, or osseous. They can be monophasic when there is only one component, or biphasic when there are two or more components. And if there is more than one component, we have to note each component and record its approximate percentage. They are classified as epithelial only carcinomas, which include adenosquamous and squamous carcinomas, pure sarcomatoid carcinomas, and biphasic epithelial and sarcomatoid carcinomas. Keratins are always expressed. More than 90% lack ERPR and HER2. Lymph node metastasis is less frequent, and they are associated with lower response rates to conventional chemotherapy and a worse clinical outcome after chemotherapy than other forms of TNBCs. 5-year overall survival rate is 62%. Now, prognostically, the low-grade adenosquamous carcinomas and fibromatosis like metaplastic carcinomas are indolent and show favorable prognosis. Metaplastic carcinomas with heterologous mesenchymal differentiation, which can come in the form of chondroid, osseous, rhabdomyoid, or neuroglial, shows a better prognosis. High-grade adenosquamous carcinomas, squamous cell carcinomas, and spindle cell carcinomas show the worst prognosis. This picture on the left shows fibromatosis like metaplastic carcinoma with this cluster of epithelial differentiation in the center. And this picture on the right shows a metaplastic carcinoma with heterologous differentiation in the form of cartilage. Then we have salivary gland tumors in the breast. So normal breast and salivary glands, they share a similar architecture and a similar cellular composition. So the breast can develop the entire range of tumor types which are encountered in the salivary gland. So these include acinic cell carcinomas, adenoid cystic carcinoma, secretory carcinoma, mucoepidermoid carcinoma, polymorphous adenocarcinoma, and tall cell carcinoma with reverse polarity. Now, these tumors share the similar morphology as well as molecular alteration as seen in their salivary gland counterparts, but the clinical behavior is different. They are TNBCs but still show low or intermediate grade aggressive potential. Then we have the garden variety, that is the invasive breast carcinoma of no special type, which is the most common variety seen in our daily practice. This is a large and heterogeneous group of invasive breast carcinomas that cannot be classified morphologically as any of the special histological types which I just described. The features vary considerably from case to case, and within the same case, the margins can be infiltrating or pushing. The cells can be arranged as cords, clusters, trabeculae, solidness, syncytial sheets, tubules, or single file pattern. Mitosis and necrosis is variable. Stromal component can be highly cellular to scanty. It may show marked hyalinization, elastosis, or inflammation. Like in this picture, we can see that the stroma is inflamed. It is associated with DCIS. Associated DCIS is seen in 80% of these cases, and lymphovascular and perineal invasion is seen in 20 to 30% of these cases. And it is called as mixed when there is a mixture of IBC, NST, and a special subtype which constitutes 10 to 90%. In these cases, we have to report both the elements as well as the overall percentage of the special subtype. And we have to report grade and biomarker status of both the elements. In this example, we have IBC NST on top and invasive lobular carcinoma on the bottom. Now, there are special morphological patterns seen in these tumors, like the medullary pattern, pleomorphic pattern, choriocarcinomatous pattern, etc. And these are just patterns and not subtypes because there is insufficient clinical evidence available for their designation as special tumor subtypes. And that's why these patterns are just considered part of the spectrum of differentiation seen in IBC NST. Next is invasive lobular carcinoma. This is the invasive counterpart of LCIS, composed of discohesive cells which are individually dispersed or arranged in a single file linear pattern. It comprises of 5 to 15% of all invasive breast carcinomas. And again, the most consistent molecular alteration is loss of E-cadherin expression. They are ERPR positive, HER2 negative, and various morphological patterns can be seen like classical, alveolar, pleomorphic, solid, or mixed pattern. Here we have the classic pattern in which we have small uniform nuclei dispersed in single file pattern in the stroma. Then we have the solid pattern invasive lobular carcinoma. Then there is this pleomorphic invasive lobular carcinoma, shows highly pleomorphic discohesive cells dispersed through the stroma. And on IHC, these cells show E-cadherin negativity. Then comes the histological grading, which is done using the Nottingham Combined Histological Grade. It includes 3 parameters: tubule formation, nuclear pleomorphism, and mitotic activity. Now, tubule formation is assessed throughout the whole tumor at low magnification, and only structures that exhibit clear central lumina are taken as tubules. So, if the tumor shows more than 75% tubules, it is given as score 1, 10 to 75% score 2, and less than 10% is score 3. Coming to nuclear pleomorphism, this is again divided into 1, 2, 3 as mild, moderate, and severe. Mitotic activity is assessed in the area showing highest frequency of mitotic figures, that is the hotspot area. So 0 to 8 for 10 HPF is score 1, 9 to 17 is more than is score 2, and more than equal to 18 is score 3. And only definite mitotic figures are to be counted. Hyperchromatic and pycnotic nuclei are to be ignored. And also these mitoses are according to the microscopic field, because they are standardized to a fixed field area. So in the end, all the three scores are added to arrive at the final grade. So 3 to 5 score is grade 1, 6 to 7 is grade 2, and 8 to 9 is grade 3. So coming to the last part of my talk, which is biomarker testing on breast cancer samples. So standardized hormone receptor and HER2 testing is done on all primary as well as recurrent or metastatic invasive cancers to determine overall treatment pathways and specific therapy options. Core needle biopsy samples are preferred at the time of primary diagnosis, and if these biomarkers are negative on a core biopsy, repeat testing can be done on subsequent specimen. Also, if you have multiple invasive foci, test the largest invasive focus, and smaller focus needs to be tested if it is of different histological type or of higher grade. This can also be performed on cytology specimens, preferably formalin fixed cell blocks. ER and PR testing is done to predict which patients may benefit from hormonal therapy as well as to determine overall treatment pathways and risk reduction strategies. ER positivity is seen in 75 to 80% of invasive breast cancers, almost all grade 1 and most grade 2 cancers. And in DCIs without invasion, ER testing is done to determine potential benefit from endocrine therapies for local recurrence risk reduction. So the reporting is done using the CAP ASCO reporting guidelines. In this, we have to record the percentage of positive cells, which can be a specific percentage or within a range. And also we have to give the intensity of nuclear positivity, which can be weak, moderate, or strong. The average intensity is included in the report. So these are the ER result categories. So it is called as positive if more than equal to 10% of the tumor cell nuclei show immunoreactivity. Low positive when 1 to 10% of nuclei are immunoreactive, and negative if it is less than 1% of the tumor cells which are immunoreactive to ER. So these microphotographs show the different ER scores. So A and B pictures show 90 to 100% cells showing strong intensity. In the C and D, we can see 70 to 80% cells showing weak to moderate staining. And E and F is ER low positive because only 1 to 10% of the cells are showing weak intensity staining. G is 0% staining, and H is negative because the tumor cells which show positivity are less than 1%. Next comes HER2 testing. HER2 overexpression is seen in 10 to 20% of invasive breast cancers, and it is a distinct subtype with aggressive behavior and biology. It is both a prognostic and predictive biomarker in breast cancer. A positive HER2 test is predictive of survival benefit when HER2 targeted therapies are added to the chemotherapy schedules. Clinical guidelines such as NCCN, they utilize HER2 status to determine overall treatment pathways because of its prognostic and predictive value. So these are the result categories for HER2. It is in negative, we have three categories. Negative score 0 is when there is no staining. This is also called as HER2 null. Negative score 0 plus is membrane staining that is incomplete and is faint or barely perceptible within less than 10% of the tumor cells. This is HER2 ultra low. Then we have negative 1 plus when there is incomplete membrane staining that is faint, barely perceptible, but in more than 10% of the tumor cells. This is HER2 low. Then we have equivocal or 2 plus. This is when there is weak to moderate complete staining in more than 10% of the cells, or complete intense staining but in less than 10% of the tumor cells. Score 3 plus is complete membrane staining that is intense and in more than 10% of the tumor cells. So this is the algorithm that we follow for HER2 interpretation of HER2 IHC staining. We have to look for membranous staining, whether it's present or absent. If absent, it is score 0. If it is present, we have to look for completeness. If it is incomplete, faint, barely perceptible in more than 10%, it is called as -1 plus. If it is complete but weak to moderate in more than 10%, it is equivocal 2 plus, and it is sent for reflex-ish testing. And if it is strong in more than 10%, it is positive, taken as positive 3 plus. Most anti-HER2 therapies are approved only in, they were approved only in HER2 positive tumors till now. However, more recently, HER2 ADC antibody drug conjugate has been approved for treating metastatic invasive breast cancers that are HER2 null, low, or ultra low. We should also correlate biomarker status with specific histological features and look for any discordance. For example, if in IDC or ILC which shows low ER and is HER2 positive, we should relook at the histology. Lastly, Ki67 testing. This is a nuclear protein found in all phases of the cell cycle and is a marker of cell proliferation. It can be easily assessed using IHC. Presently, it is not been validated as a predictive biomarker because there is a lack of international consensus about its scoring and cutoff value. Also, it is not very reproducible, but it may be reported as an additional data element in breast cancer characterization and reporting. And a threshold of 14 to 15% has been proposed, in which Ki67 more than 14-15% is taken as more aggressive and less than 14-15% is taken as less aggressive. This is the template for biomarker reporting which we follow in our department: ER, PR, HER2, and Ki67 staining. To conclude, histological types of breast cancers are prognostically relevant, so it is important to classify and allocate a definite category. Also, histological grade and biomarker results influence treatment strategy, so it is imperative to correctly grade and interpret biomarker results in these tumors for optimum management. These are my references, and with this, I would like to end my presentation and extend my thanks to Dr. Vaishali and other members of the organizing team for giving me this opportunity, despite my ability to present the talk live. Thanks again.
Thank you, Dr. Garima, for this insightful talk. Then we session. Uh, Whenever there is an expert pathologist, those expert pathologists, they also need that specimen should be handled properly. Otherwise, many of the reporting becomes very difficult, many of the parameters. So for this, I would like to invite Dr. Neha Kapoor. She is a pathologist from she's a pathologist, and we have worked together, and she would be the perfect person uh, to tell us in detail how it should be handled. I welcome you, Dr. Neha.
Thank you, Dr. Safalta. Good evening, everyone. I'm Dr. Neha, and I'll be presenting. Just one second. Is my screen visible to everybody?
Yes, ma'am.
Yes.
Just put it on presenter mode.
Okay. Yeah.
Done, ma'am.
All right. Thank you so much. So, good evening, everyone. I'm Dr. Neha, and I'll be presenting about the handling of the breast specimen, starting from OT to the lab. Now, we all know there are different type of specimens, ranging from mastectomies to lumpectomies, shave margins, sentinel lymph nodes, and once we start from OT, So, what are the precautions that we take from OT handling? First of all, when you take out the specimen, it should be immediately placed in the container filled with formalin. That is the cold ischemia time. So, the cold ischemia time needs to be as less as possible. Less than 1 hour is ideal. It should not exceed more than that. Once the specimen is placed, the container should be labeled properly. And in case if you are sending a lumpectomy, there should be proper orientation sutures. Normally, you have a short suture for superior, a long suture for lateral. So, whatever protocol is followed in your institute, and then in case there is a J wire or clip present, then that needs to be mentioned on the form. Once you are transferring the specimen in the container, please make sure that the container you choose is proportional to the size of the specimen. Because when you try to fit a large specimen in a small container, it would lead to crushing of the tissue, and that damages the specimen because it is fresh when you're sending it for frozen. Also, try to lessen the cautery artifacts as much as possible. And if you are sending the specimen for frozen, then please do mention on the form what is the indication for frozen, like it's a margin assessment, tissue diagnosis, a sentinel lymph nodes should be clearly mentioned. The specimen that you are sending, the container that you're using should be properly labeled with the patient's name, hospital ID, left, right, orientation markers should be clearly mentioned. The requisition form should include the surgeon's orientation sutures, what protocol you're following. Short is usually superior, long is usually lateral, medial is medial. Sometimes anteriorly a loop is placed, sometimes there's a skin ellipse, and sometimes the posterior margin is also inked. So whatever protocol is followed between you and the surgeon. Then it should be clearly mentioned the lesion location, whether in terms of a clock position like 3 o'clock, 4 o'clock, or a quadrant, or a distance from the nipple in case nipple areola also has been removed. Imaging findings should be clearly mentioned. In case it's a post NACT specimen, please do mention the status that it is post NACT. So we know we are looking for a tumor bed instead of a viable tumor. And if there is any microcalcification, a clip has been placed or a J wire has been placed. So please do mention that with the reason for placement. And like I said, record the time of excision and the time that is placed in fixative, which is the cold ischemia time. Keep it as low as possible, less than 1 hour. Transport the specimen fresh if you're sending a frozen section without any medium. And otherwise, you send it in 10% neutral buffered formalin. For biomarkers like ERPR, hernia, the cold ischemia time becomes even more important, so keep it ideally within 1 hour of excision. The specimen, once it is removed, it should remain in 10% neutral buffered formalin for a minimum of 6 hours, ideally 48 or not exceeding 72 hours. Over fixation or under fixation, both will have their own issues. Then comes packing and fixation. So this is just to show you a container that has a mastectomy specimen in it. It has to be filled properly with formalin. The ratio is usually 10:1. So there should be abundant formalin when you fill up the container. Because the breast tissue usually tends to float above, so we cover it with gauze pieces or cotton just to make sure that it is immersed properly in the formalin. Now, in our case, once we receive the specimen from OT, we usually transfer them in bread boxes. This is just a picture to show you. Normally, they are much bigger and wider in lengthwise also. So, lumpectomies are usually received as frozen specimens. So, we slice it and fix it accordingly. But when you get a mastectomy, they usually come in containers which are already in the OT. So, you have to transfer it. And then we transfer the mastectomy specimen into a bread box, so it gives it more space. Orientation is maintained, the structure of the breast tissue is maintained. Here, if you put it in a container, it may get distorted after fixation because the tissue thickens. So we immediately place it into a bread box and then we fix it. Now, after slicing, you slice the tissue. I'll just show you in the next picture. This is a mastectomy specimen. So in this particular case, you can see that this. So this is a mastectomy specimen. You take it in 3 dimensions, and then you take measurements of the skin ellipse. Again, 2 dimensions of the skin ellipse are taken. Once you send mastectomy, it is important to place the sutures for orientation. Like here, you can see there is a short suture for superior and a long suture for lateral. If the mastectomy specimen comes with a nodal dissection, then you may not need orientation. But like in our institute, we get two containers usually, one with the mastectomy and one with the nodal dissection. So in that case, you should place orientation sutures for your pathologist or do a cautery mark or on the lateral aspect, like whatever protocol is comfortably followed between you and your pathologist. And this is the posterior surface in the other photograph. Somehow my scroll pad is not moving. So this is the other photograph which shows the deep or the posterior margin, which is usually inked black. Now, in cases of mastectomy specimens, we usually only ink the posterior surface. 1 second. So this is again a specimen that is showing that it has been serially sliced. And yes, so this is how the specimen looks like. It is serially sliced and you can see a grayish white tumor in between. Now I'm just exiting because my mouse is giving me some trouble. 1 second. So I don't know why the mouse is not moving. It is moving here. Anyway, so this is how the slices look like after fixation, and you can see a grayish white tumor here. Now, in mastectomy specimens, the closest margin is usually the posterior margin. So we ink the posterior margin and take a distance from the margin. You can also take the tumor size, record the tumor focality. If there are multiple tumors or a single tumor, and then the tumor site size and focality is recorded. High-grade DCIS can form a mass-like lesion, but low-grade DCIS usually does not. In a mastectomy specimen, usually closest is posterior, which is recorded, but if you find some other margin which is more closer, you can take it accordingly. If the tumor is more on the medial aspect or on the lateral aspect. So depending on the location, you can always take the closest margins. Then if there are multiple tumors, then you must record the distance between the two tumors. Usually 5 distance is considered as two separate tumors. 5 distance is, if there is 5 distance between two tumors, then it is still considered as one lesion. But if it is more than 5 then they are considered as two separate tumors. So you mention all the parameters for both the tumors, and while sectioning, take a section in between the tumors also. So this is again a photograph showing a grayish white spiculated tumor on the slice. And then this is a mastectomy specimen. Again, you can see that there is a posterior margin has been inked. There's a grayish white tumor here. This is a lumpectomy specimen which has been inked. Now, a lumpectomy specimen usually has 6 margins, so you ink all the 6 margins. It is important to differentiate the inks. So try not to take two similar looking inks very closely because they can overlap with each other. So usually what we do is we put red on medial and orange on lateral, so they are very far away from each other. And when you take a section, there is no ink mixing. If you take two different type of inks, it is always better. This is again a radiology specimen just to show that a J wire or a clip may be placed, and accordingly the sections need to be taken. You need to identify where the lesion is. There is active communication required with your surgeon to understand why the clip has been placed or the J wire. In the second photograph, there are 2 lesions, so there are 2 clips and 2 J wires. At our institute, we do have a WhatsApp group where they put all the mammo photographs before we get the frozen specimen. So there is a very active coordination. We can always correlate with the photographs. This is again a lumpectomy specimen which has been inked and then serially sliced. And once you slice it up, you identify the lesion, take distance from all the margins. If there is a skin ellipse, then you have to examine the surface of the skin. If there's any ulceration, any satellite nodule, and if nipple areola is included, then the status of nipple, whether it's retracted, ulcerated, that is important. Again, a photograph showing a lumpectomy which has been sliced, and these are the cassettes that we use where the tissue is put in and then it is processed. Now, something about shave margins. Shave margins can be taken as frozen sections also, and they can be done for revision also. So sometimes the surgeon prefers to do a lumpectomy specimen and send the shave margins as frozen in separate containers labeled as superior, inferior, medial, lateral, and these specimens are sent for frozen and the lumpectomy is sent later as a permanent specimen. So in such a case, when you get a shave section, you have to ink two surfaces. So it is important that your surgeon should label which surface is towards the cavity and which surface is away. So usually they ink one surface which is away from the cavity. Now the surface which is away is actually the true margin. So once we receive it in the lab, we will ink that surface with one color, the other surface with a different color, take perpendicular sections and then examine them. So in case there is a tumor deposit on any section, you can give a clear distance from the true margin. And of course, if there is ink on tumor, then it will be a positive margin. The other thing is shave margins are sent as revised margins. When a lumpectomy specimen has been received in frozen, and the one of the margins has come positive or it is very close and the surgeon wants to revise it, then they again send a shave margin. Either way, it is very important that your form mentions clearly what the inking means, whether it is towards the cavity or away from the cavity, and it is clearly explained to your pathologist. So I think this we have already covered, how to fix it and how to take the sections. And once you take the sections, they are put in cassettes, which should not exceed 3 mm. The thickness of the tissue is not more than 3 mm to ensure good fixation and processing. Do not overfill the cassette, labeled it properly. And if there are, you can also use diagrams and maps to explain how the sections have been taken, just in case if it is needed, especially in complicated cases. Now, this is another photograph which shows serially sliced mastectomy specimen. In this particular case, this area that has been marked here, this is actually a tumor bed. So this is a post-NACT specimen. When you get a post-NACT specimen, first of all, please do mention on the form that it is post-NACT so the pathologist is aware. The previous biopsy, if you have the results, whether what type of carcinoma it was, especially if it is lobular, because they are more notorious and they tend to go beyond the margins, they will have more positive lymph nodes. So it is important to give the histology to your pathologist. Also, if there is any other radiology imaging, if a clip has been placed, this is a mastectomy. If you get a lumpectomy, then a J wire is placed. So please do mention everything on the form. And when we get the specimen, then we excise the tumor bed. Usually, we are able to excise it entirely because it is shrunken and there's fibrosis after NACT. But in some cases, you may have a much larger tumor bed, and then you may not be able to process it completely. It depends. And also, there are times when there is no response to therapy, so you may get a very clearly visible tumor grossly. So you have to take sections accordingly. Generally, what you see is a fibrotic tumor bed where you grossly cannot identify how much tumor is left or if there is any tumor at all. So the tumor bed is excised along with the closest margin and then it is placed in cassettes. And orientation is done as per the pathologist, how they follow the protocol in their institute. So this is just a diagrammatic representation to show you this yellowish area is the tumor bed, which was the actual size of the tumor pre-NACT. And these bluish nodules is the remaining tumor, which can be seen as multiple foci throughout the fibrotic bed. It is important that when we take the size of the invasive focus on microscopy, we take the largest contiguous focus. That means where the tumor cells are continuously together. If they are separated from each other, then they are considered as separate foci. But grossly, it is important to understand because grossly we will take the size of the tumor bed because we cannot identify the tumor foci which are seen microscopically. And tumor bed size is important for RCB calculation in case you are doing that at your institute. For teeth staging, you may not require a tumor bed. You actually require the invasive tumor size, which you calculate on microscopy. Then a bit about axillary nodal dissection. So if you get axillary nodal dissection in a separate container or along with the mastectomy specimen, you remove the fat, dissect out the nodes, take the dimensions and serially slice them, look for any necrosis, discoloration, fibrosis. For small nodes, they can be entirely placed in a cassette. For a larger node, you may have to serially slice them. The section's thickness should not be more than 2 to 3 mm. And in case you see a grossly positive node, then of course you can just take a representative slice and you may not need to entirely embed the lymph node. Now, like we just discussed, there are certain special situations, like if it is post NACT, then tumor may be partially or completely regressed. So you sample more extensively, embed more areas if required. Nowadays, almost all the specimens do carry a metallic clip or they are marked by a J wire. So mostly they are easy to locate. In case not, and sometimes because of NACT, the entire breast becomes fibrotic and rubbery. So it may be very difficult to find the tumor bed. In such cases, it is important to communicate with your surgeon actively, look for pre-NACT radiology, the tumor size, quadrant, and they may help you in determining where the tumor bed lies. In multifocal, multicentric tumors, give all the parameters, take separate sections from the tumors as well as their closest margins. Specimens which have clips or microcalcifications, they will be localized by J wire, so that can help you around. Re-accession, shave margins, we have already covered. Again, certain specimens may just have extensive DCIS. So in such cases, you need to take more sections because extensive DCIS is very commonly associated with microinvasion, which is not visible grossly when you look at the specimen. So you have to take a lot of sections, do extensive sampling, so you make sure you're not missing out any microinvasion. And of course, if there's a grossly visible tumor, then it is right there. Now I've finished basically grossing and fixation of lumpectomies, mastectomies, axillary nodes. Now a little bit about frozen section. So principle is basically that the tissue is frozen, the water in the tissue turns to ice and it becomes firm enough that we can cut it in a cryostat machine. What are the indications for frozen? So it should be clearly mentioned on the form when you send it to your lab, whether it is a margin assessment, whether it is a primary tissue diagnosis, or it is a sentinel lymph node. And of course, every time when it is a post-NACT case, please do mention on the form. Now, what the pathologist should know, of course, you should have a cryostat machine available. The temperature should be maintained. You have the clinician's number, the history, the radiology, everything is there. And what is the indication for frozen? This is a frozen requisition form that we use in our lab. So this has been filled. This is usually filled up before you send the frozen. Ideally, it should be sent a day before. So the lab is prepared that you're sending a frozen around this time. What is the indication? What is the type of specimen? Any history that is required? Everything is mentioned on there. So we are also aware that a frozen section is coming for this particular indication. Now, during frozen, when the pathologist is grossing the specimen, it is important to make sure that you select the representative area from where you want the closest margin cut. It has to be cut at the right temperature. Now, breast tissue is very fatty, so it gets difficult to cut frozen sections. But still, if your technician is good, if your machine is good, you can actually get some very nice sections out of it. And at least at our lab, our frozen sections are very good, like especially the lymph nodes. So sample once collected, it should be sent to the lab immediately for frozen as soon as possible. Please don't delay it. It has to be sent without a medium. And common problems that you may encounter would be specimen identification or orientation. So you immediately call your surgeon, discuss with them before you slice it up, because once you've sliced, then it becomes a problem. There might be difficulty in certain lesions to decide whether it is benign or malignant, especially when it is a low-grade DCIS or a UDH. So it may sometimes be difficult and you have to then defer it to a permanent section. There can be artifacts during frozen, which are more than you see in a formalin fixed specimen. But still, if your technicians are well trained, then you can get very good sections also. And because breast has a lot of fat, so definitely cutting of the fat becomes a big problem. Now, when you receive a specimen, this is just to show you the label should be proper, the specimen details, and everything is mentioned, whether it is sentinel, non-sentinel. This is how the frozen should be sent without any medium, absolutely fresh, no formalin. This is a cryostat machine or a frozen machine. And these are small chucks in the second picture on which we place the frozen section, the specimen that we have cut. And this is the embedding medium required. There are various shapes and sizes of chucks available. You can differs from lab to lab. Then there's something called as face up embedding and face down embedding. Usually we do a face up embedding, in which we take sections directly from the surface. Then for grossing of the sentinel lymph nodes, again very similar to what you do in axillary nodal dissection. So the size of a grossly positive node should be recorded. When you can see clearly is a positive node, just take a representative section, get a slide made out of it, and contact your surgeon immediately that the lymph node is positive. And you can defer the rest of the nodes for permanent section. So the time is saved. Unless your surgeon really wants to know how many out of them are positive, which is usually not the case. So if they know the lymph node is positive, then they can go ahead. If grossly it is a negative node, then you need to process the entire node completely. Small nodes are completely processed and larger nodes will be serially sliced. Now, as the number of slices increases, obviously the errors also come down. But for frozen section also has its limitations. So we cannot take a lot of sections. There will be limited sampling, but still you can try to give the best out of it. So this is a photograph which shows the lymph node dissection, and ultimately the fat has been removed. And this is in the last picture, you can see the lymph node which has been dissected out. This is again another lymph node which has been sent for frozen. This is a large lymph node, so it has been serially sliced in two halves, and grossly does not look positive. So you will process both the halves to see if there is any metastasis. Once you place them, once these lymph nodes have been cut and they are placed on these chucks, frozen embedding medium is added. And once they are freeze, this is how they look like. So basically you have frozen the tissue. Usually the temperature is -25. And then the sections are cut out of it. This is the same lymph node that we saw. Now it has been placed on a chuck and it has been frozen. So sections are being taken. When you take the sections, this is how your original lymph node looked like. But when you take the sections on a slide, this transparent thin film is what the section looks like before staining. So when your technician is picking up the section, it is a transparent thin film and very difficult to do. So your technician should be very good. And once it is stained, this is how it looks like. Now a little bit on histology. So when you see a lymph node, there is a fibrous capsule around it, and the area below it immediately is the subcapsular area, which is the most common area where you'll find the metastasis. So very important, when you see the sections, then you examine the entire circumference of the load, starting from the subcapsular area, because that is where you expect to get the deposit. And of course, your section should be good enough that that area is preserved and you can actually look for any mets. Now there'll be always some problems and pitfalls, like if there is tumor present on the frozen section, but it is depleted on permanent, or the size of metastasis may vary. So it is important to tell your surgeon the size also when you see the frozen section slide, whether it's a micromets or a macromets, as far as you can tell. And usually if you take multiple cuts, like we take 3 deep cuts of all frozen lymph nodes, only for lymph nodes. So after that, there is almost 0% discordance between frozen and permanent section. But yes, if you take less sections, there is always a chance that the frozen section is negative, and later on you may find a deposit in your permanent section. Usually it happens in micrometastasis, which may later pop up in a permanent section. But if you take 2 or 3 deep cuts, usually that problem does not come. Of course, the morphology gets compromised compared to formalin fixed specimen, but again, it depends on your technician and their training also. Overall, it is important to have a right communication with your surgeon. If there is any uncertainty, if you're not able to make a diagnosis, it's better to defer it rather than over or under diagnose. If you need more sample, more margin, or more notes, then you need to actively communicate with your surgeon and it can get resolved there itself. So I'm just about to end my presentation. So overall, whatever we have discussed, certain pitfalls that can come is tissue crushing while you're placing them in the container in OT. So please use a larger container. Cautery artifacts should be as minimal as possible. Loss of orientation may be there. So whatever sutures, whatever orientation you're using, please do convey to your pathologist. And incomplete fixation can lead to a lot of errors. And it can also distort your ERP or Hertinu fixation. So the cold ischemia time should be as less as possible, and formalin fixation should be ideally done. Margin shrinkage happens when you do a formalin fixation. So that is around 2 mm margin fixation can occur. Now, this is important in lumpectomies, but lumpectomies mostly come as a frozen section, which is a fresh specimen. So there is no shrinkage during that time, and you can ideally take the distance from margins, the tumor size, everything. This is more important when you get a formalin fixed sample. So then there is some shrinkage of the tissue. Certain things we can do to minimize it is photograph the whole specimen before slicing, after slicing. If you feel it's complicated, then take as many pictures you want, and you can later correlate with them when you're doing your microscopy. So that is actually very helpful. And radiography, of course, you need to correlate with the radiography also to look for any microcalcification, clips, J wire. It has to be mentioned clearly by the surgeon also, radiologist also, and the pathologist actively communicates with them. In case a grossing map or diagram is needed, we can go for that. Document the cold ischemia time, the fixation time, any deviations. And of course, if there's any doubt, then you consult with your colleagues. And that's it. At the end, I think I've covered almost everything. So if we take care of certain basic things, then actually the quality of reporting and the final would be really improved. So just little small points that you can take home and make sure that errors are reduced as less as possible. I think overall the best thing is to have a very good communication with your surgeon and that you are on the same level, whether it is about orientation, the type of specimen, sectioning. So as long as there is active communication, I think the errors come down a lot. So I think that's it. So that's the end of my presentation. I hope I've not exceeded the time. And
Definitely not, Dr. Neha. It was such an excellent presentation. And I request you to stay back till our panel discussion, though you have covered many of the questions now itself.
okay.
I would like to ask the audience if they have any question, they can put in their QA box, which we'll be asking to the speakers, as well as we can cover it in the last or in the panel discussion. Then I would like to invite Dr. Gaurav Khanna. He will be taking this session on the optimal reporting of the pathology specimen. So it's very important for us because everything, every parameter, it makes our decision easier for whether to give adjuvant or not, how to upgrade or we de-escalate the treatment. So I welcome Dr. Gaurav Khanna, who is actually a very strongest pillar of oncology department at Amrita Hospital. Uh, I welcome Dr. Gaurav Khanna.
Good evening, everyone. Hello, Dr. Safalta. Good evening, everyone. And
And
hope I am audible.
yes, you are audible.
And my screen is also visible.
Yes, you have to make it a slideshow.
Okay. Yes, now I think it is visible in the slideshow.
Yes.
Okay, first of all, I would like to thank you everyone for taking me on this platform, for giving me this opportunity. And I think Dr. Neha Kapoor has already done quite a decent job. She has covered almost every aspect, and especially the grossing aspects, which I am going to deal with, and especially the what is optimal pathology report, because optimal pathology report can be done only if the specimen is grossed adequately. Uh, what is the need of optimal pathology report? The need of optimal report is to have an accuracy, to the report should be complete. That means it should cover all the aspects as far as treatment aspect is concerned. And then the reports should be comparable to different centers as well. So, like if we are sharing a report with someone else, pathologist, someone at some other center, or if the clinician is sending the blocks to some other place, the report should be comparable. So if there is a standardization of report, then only the reports can be comparable. Then consistency in the terminology. So these are the four important points which are important to have a report, which are important to have in the report. So to have these features, to have accuracy, to have completeness, comparability, and consistency in terminology, there are standardized set of data points or checkpoints or some important points which should be mentioned in each and every report of these breast samples, be it core needle biopsy or post NECT specimens. So for standardization of these set of data points, there are some global bodies, some regional bodies. Some global bodies are like College of American Pathologists and one international collaboration on cancer reporting, ICCR guidelines. So these are the global bodies which offer a standardized set of checkpoints or a list of these data points on the basis of which any pathologist can report without missing any important information required for clinician. Similarly, there are some regional bodies like Royal College of Pathologists, Royal College of Pathologists of Australasia, or Korean Society of Pathologists. Recently, International Academy of Cytologists have also offered a Yokohama system for reporting of aspiration cytology of breast lesions. Uh, I wanted to escape this, yes. So, International Academy of Cytologists have also given a Yokohama system of reporting aspiration cytology of breast lesion, which divide the breast lesions on aspiration cytology into 5 categories like insufficient, benign, atypical, suspicious, and malignant. So these provide a standard set of protocol on which basis biopsy or a specimen should be reported. Narrative reports are not recommended because they are highly variable and there are high chances of missing key information. So if some clinician is still having the descriptive reports of a breast specimen, one should ask their pathologist to follow these protocols and report under these protocol set points. So narrative reports are should be discouraged and are not recommended. So before going for what should be the components of the optimal pathology report, our pathologists also deserve some some information from the clinicians, especially like for pre neoadjuvant therapy core biopsies, localization of tumor, size of the tumor, what is the BI-RADS category, what are the number of lesions, if there are multiple, then which lesion is targeted, whether there is any microcalcification, total number of core samples, and cold ischemia time. Recently, we have introduced this cold ischemia time as per the NABL guidelines also. We must mention the cold ischemia time in our reports because this affects the ERPR and HER2 performance of immunohistochemistry in the specimen. Then for post neoadjuvant therapy breast samples also, we need some important crucial information from the clinicians like which protocol was given, what was the clinical staging before treatment and after treatment, what was the diagnosis of pre-neoadjuvant therapy, and what was the biomarker status, what was the size and location of the residual tumor, then whether there is any presence of CLIP or any other marker for identifying the tumor. So these are the standard checkpoints or data set for a pre-neoadjuvant therapy biopsy. What was the procedure done? What is the histological type of the tumor? Histologic grade of the tumor, as already Dr. Garima has discussed, the Nottingham grading system, which includes tubular differentiation, nuclear pleomorphism, and mitosis. Then ductal carcinoma in situ, along with its details like what is the architecture and what is the grade of the DCIS component, whether there is any necrosis, microcalcification, lymphovascular invasion, and the hormonal status. Additional findings like tumor infiltrating lymphocytes in HER2 positive tumor and TNBC triple negative breast carcinomas is still not included in the CAP protocol. But if some patients are involved in some clinical trials, or if the clinician is asking for tumor infiltrating lymphocytes, then they can be mentioned. As of now, mentioning tumor infiltrating lymphocytes is not being included in any of these set protocols. So now coming to the reporting of post-neoadjuvant therapy specimens. Post-neoadjuvant therapy reporting is still highly variable. At some places, pathologists are including the RCB index score. At some places, pathologists are using the old one, the Miller-Pine scoring system for identifying the percentage of the residual tumor. But recently in 2024, CAP protocol has included the RCB index system. So I will discuss that RCB scoring system, how to calculate it and how to do it. So it is highly variable because mostly the pathologists are not aware of the prognostic importance. Most of the places are clinically driven. Pathologists mention in the report what the clinicians are asking. If they want it, then they mention it. If they don't require it, then at places pathologists don't don't mention the post-nat status, the amount of residual tumor or RCB index. And many of the pathologists are still unaware of any existing recommendations. This is as per the article which has been published. So International Working Group recommends reporting of some additional elements which have been recently incorporated into CAP cancer protocol in 2024. Before going into these details, the additional elements, what are these additional elements? 4 possible ways in which the tumor responds to neoadjuvant chemotherapy are complete. Either they undergo complete pathologic response, they undergo partial pathologic response, no response but the disease is stable, or they may progress even on chemotherapy. So what are the, before going further, I would like to throw some light on the previous classification systems which were used for evaluating pathologic response to neoadjuvant chemotherapy. So there are many scoring systems, and there for defining pathological complete remission, some of these systems need assess the breast as well as the lymph nodes, while some of them assess only breast. Like Miller-Pine score, when I during my senior residency in AIMS, their Miller-Pine scoring was done, and their Miller-Pine scoring includes only breast as for assessment of post-neoadjuvant therapy status. That means complete remission is there or not. So lymph nodes are not included in this, and and it needs the comparison of the previous core biopsy. So if you don't have the previous core biopsy, then it may be difficult to assess the Miller-Pine scoring. This is the one of the disadvantage. The another disadvantage is when you are comparing from a pre-treatment core biopsy. The core biopsy may not be entirely representative of the entire tumor because the tumors are heterogeneous. They have some grade of fibrosis. Some areas are more cellular, some areas are less cellular. So it may not be entirely representative, but yes, it was good to at least utilize some scoring system. But all the latest scoring systems like residual cancer burden or the AJCC system, they do not need to hide this. Yes. So they do not use this pre-treatment comparison. So as per the AJCC system or the residual cancer burden system, we do not need pre-treatment core biopsy assessment. But still, we should be aware what was the cellularity status, what was the biomarker status, what was the histological grading. For all these comparison, we must have a core needle biopsy with us while reporting a post NACT specimen, but it is not required for comparison of cellularity, which was required in Miller-Pine scoring system. Yes, DCIS was same. The presence of DCIS only in the absence of any residual tumor is still pathological complete remission. We will discuss what are the criteria for calling a pathological complete remission. So DCIS, as far as DCIS is concerned, all the scoring systems have same acceptance for a DCIS. That is, if there is presence of only DCIS and there is no residual tumor in the tumor bed and no residual tumor in the lymph nodes, it will qualify for pathological complete remission. But the only change in AJCC system and residual cancer burden system is that they don't require pre-neoadjuvant chemotherapy core biopsy. So these are the response. Like this is a complete response. The pre-treatment tumor is completely dissolved and entirely replaced by fibrosis, cholesterol clefts, and histiocytic aggregates and scattered lymphocytes. The most common scenario in which the treatment response is seen is like we see some residual scattered tumor cells in the tumor bed, and the tumor bed gets in the tumor bed, the original tumor bed can even expand, or it can shrink also. And the rare scenario is concentric shrinkage, that is the tumor cells concentrate in a smaller area and the entire tumor bed is shrunken to a smaller size. So this is the rare kind of scenario. The most common type of pattern which we see post NACT is that we see only residual tumor cells scattered with intervening large amount of fibrosis and collection of histiocytes and cholesterol collects. So this is the most common pattern. So I am discussing these three types of patterns because this will help in the assessment of tumor size and residual tumor size and the residual tumor bed, which are most important for assessing the residual cancer burden. So the one of the most important additional element for post neoadjuvant therapy specimen is size. Because to calculate the residual cancer burden, we need size of the tumor, size of the residual tumor bed, and cellularity of the residual tumor. So the size, if we discuss the size, there are three different types of size which we are concerned. One is the tumor bed size. So tumor bed size is defined what is the size of the tumor which was pre-neoadjuvant therapy size. So this tumor bed size includes the intervening desmoplastic stromal reaction of tumor because the tumor incites some reactive fibrosis in the mesenchyme. So that kind of fibrosis is included in the tumor bed size when the specimen is pre-neoadjuvant therapy. Then there is one term residual tumor bed size. This residual tumor bed size is post-neoadjuvant therapy and it is calculated for residual cancer burden. And the amount of fibrosis in between the two residual invasive tumor foci is included in this size. Then last is residual tumor size. In residual tumor size, it does not include any treatment related fibrosis. So suppose this is the primary tumor bed or the tumor bed pre-neoadjuvant therapy, and these are the two residual tumor foci. So the distance between the two residual invasive residual tumor foci in two largest dimensions, this will be my tumor bed size. This will be the residual tumor bed size, which will be included in the calculating the residual cancer burden. And the size of the largest size of the invasive foci will be taken as residual tumor size. This I will use for YPT determination. So there are two. I will stress upon. I'm stressing upon these two things because they are very important. One is residual tumor bed size. Another is residual tumor size. For residual tumor size, we calculate the largest residual invasive tumor foci, and for residual tumor bed size, we calculate the two dimensions from one invasive residual foci to another residual tumor foci, and it should be the maximum distance. So we are not bothered about the fibrosis which is beyond this, but we have to include the area of fibrosis between these two invasive residual foci. Suppose this is a grid. Suppose this is a slice of a breast specimen post NACT, and this is one of our case from our center. So I can see here that this area up till this area, I can see this is probably the residual tumor, and this is entire is probably the primary tumor bed, but the area of invasive tumor is like this. So this size I will calculate it for calculating the my tumor stage, and these are the maximum two dimensions and this is including the intervening fibrosis. So this will be my size of residual tumor bed size, which I will use for calculating residual cancer burden. So I will process it in a grid form, mentioning all the blocks from where all the blocks have been taken. And I will specifically mention the blocks which will be containing these tumor slices, so that my size, I can calculate my size accurately. More importantly, suppose if a microscopic residual tumor foci is seen here, so naturally my dimensions of YPT will include this residual foci of tumor as well. And similarly, RCB will also, residual tumor bed size will also include that tumor foci. So it can, the actual size depends on how the specimen has been grossed, and size determined on the grossing may alter on microscopy. So the pathologist, while grossing and while reporting, one should have the printout. Ideally, one should have a printout of this slice, which has been entirely processed, entirely submitted. In addition, some areas which are adjoining areas of fibrosis should also be included in the blocks. So suppose these are the residual tumor foci. So the area of residual tumor foci, which is including the area of fibrosis in between these residual tumor foci, this will be my residual tumor bed. This will be the size of residual tumor bed. And two largest invasive foci, the distance between these two largest invasive residual foci will be used for YPT calculation. Then coming to another important element, which is cellularity. So we just do the average of each slide, how much tumor percentage is there, and we average out all the slides, along with mentioning the percentage of in situ component. So this is for calculation residual cancer burden. So far we have discussed the residual tumor size, size of residual tumor bed, size of residual invasive tumor, and cellularity. So we need all this information to be fed in this residual cancer burden calculator, which is provided by MD Anderson Institute and is available free for online. So we have to feed the tumor bed area, which we have calculated from the gross and microscopy, the two largest dimension, overall cancer cellularity, which we have to calculate on the basis of average, taking out the average, and including the in situ disease, because this in situ disease has to be excluded from this calculation. Similarly, we have to calculate the diameter of largest metastatic deposit in the lymph node and the number of nodes positive. This is how it calculates the residual cancer burden, and then it defines it into residual cancer burden class as well. So what does not qualify for pathological complete remission? If we see isolated tumor cells within the lymph nodes, it does not qualify for pathological complete remission. Even if there is no tumor cells identified in the tumor bed on extensive sampling, but presence of isolated tumor cells in the lymph node one has to refrain from calling it as pathological complete remission. Isolated tumor cells is when the number of tumor cells is less than 200. Similarly, if we see any foci of lymphovascular invasion, that again labels it as a tumor with poor prognosis or worse prognosis, then also it does not qualify for pathological complete remission, even if the tumor bed has no residual tumor or lymph nodes does not have any residual tumor cells. So foci of LVI excludes for pathological complete remission, and presence of isolated tumor cells in a lymph node also excludes pathological complete remission. If there is presence of only DCIS in the tumor bed, that qualifies for pathological complete remission. It is not a prognostic finding, and the survival rate is comparable to the patients who have no residual tumor. So in Miller-Pine scoring system also, DCIS presence of DCIS alone was qualified for pathological complete remission, and in AJCC system and residual cancer burden system, they also deal with DCIS in a similar fashion. So, is there any need of performing post biomarker studies in post NACT specimens? What are the recommendations or what are the guidelines? So, we will discuss those guidelines or indications. So, there are chances that ER gets converted, expression of hormonal receptors gets converted after neoadjuvant chemotherapy. Even HER2 phenotype can also change. It is seen that most often ER gets converted from negative to positive in 13 to 18% of cases, and PR gets converted from positive to negative in around 26 to 32% of cases, and HER2 converts from positive to negative in around 10 to 50% of cases, in specifically when treated with pertuzumab. So one should perform a hormonal receptor status in a post neoadjuvant chemotherapy residual tumor when the case is triple negative, in the primary tumor. When there was an equivocal result on pre-NAT core biopsy and biopsy sample had insufficient invasive tumor cells, if the biopsy was performed in some another institution, or the tumor was heterogeneous, or there were multiple tumors with different morphologies, or if there is no pathological response to treatment. So these are the indications when the biomarkers should be performed again on post-neoadjuvant specimen. Ki67 also plays a prognostic role in post-neoadjuvant specimens, specifically in luminal B-type cancers, in triple-negative breast cancers, and in HER2-positive breast cancers. And the comparison should also be done between the pre and post-neoadjuvant therapy. If there is significant reduction in Ki67, it is associated with favorable prognosis, exactly similar to if we are seeing a pathological complete remission cases. So, what a reporting of post-neoadjuvant therapy specimen should include some additional features. It should mention the amount of residual tumor, whether there is any presence or absence of any residual tumor. If it is present, it should be calculated with RCB score and RCB index from MD Anderson calculator. The tumor size, the primary tumor bed size, residual tumor bed size, and the primary tumor and the residual tumor size for BIPT annotation is very important. So the size should be calculated with size should be calculated very carefully, taking consideration into the gross picture as well as the microscopic picture to identify the residual tumor cells. Then treatment effect, whether there is some treatment effect is present or not in the form of fibrosis, histiocytic macrophages, and cholesterol clefts. Then presence or absence of DCIS with its nuclear grade and measurement, surgical margin status, post NACT tumor biomarkers, and Ki67 index as we have discussed. Then number of positive neoadjuvant therapy positive lymph nodes, largest focus of metastasis based on AJCC 8th edition, and the presence of extranodal invasion or any treatment effect in the lymph nodes. So we have already discussed the RCB scoring and RCB index. So what additional information is added in post-neoadjuvant therapy specimen is the RCB score and RCB index. RCB score, we need tumor bed size, residual tumor bed size, and we need for AJCC, we need the residual tumor size. These are the two important papers which we can go through for assessment of neoadjuvant cases. Thank you. I think I have covered the important aspects of neoadjuvant therapy specimens and pre-neoadjuvant therapy. Any questions? I would welcome any questions for this. And I didn't find anything more relevant for than describing the how to take the size, and there are two important size which must be mentioned in the reports.
Full talk, and actually you have also covered lot many topics, lot many questions which we have kept in the panel discussion, but stay with us for the panel discussion. Now going for the next session, that is this discussion, and our members who are the discussants are Dr. Vaishali Zamre, Dr. Prekshi Chaudhary, and myself. Over to you, Dr. Vaishali. Please introduce the participants of the discussion.
Right. So thank you, Dr. Safalta and Dr. Gaurav. Wonderful presentation, Dr. Neha too. Although you all the three talks have covered most of the questions which we were going to ask during panel discussion, but we will still try to discuss those questions which are relevant. So with me are my esteemed panelists, Dr. Rajinder Kaur Sagu, a great friend, who is a surgical oncologist and a senior director of breast cancer surgery at Max Super Speciality Hospital, Vaishali. Dr. Kuldeep Sharma is a director of radiation oncology at Venkateshwar Hospital in Delhi. Dr. Annie Ba, she is an associate professor at St. John's Medical College and Hospital, Bangalore. Dr. Neha and Dr. Gaurav, we already know. So let us begin. Sunidhi, can we have the slides?
Sure, ma'am, I'm sharing.
Sure. So it is needless to say the importance of histopathology, the immunohistochemistry in our clinical practice. However, as we all know that the practice of pathological reporting is very heterogeneous in our country, and we come across many different pathology reports which are still lacking a lot of critical information which is needed for us to take decision about the subsequent treatment. So next slide, please. I've already introduced the panelists. Next slide, please. Next slide. Next. Next. So we know that histopathology report is critical for staging, for prognostication, and for decision making in neoadjuvant as well as adjuvant treatments, and of course for predicting outcomes. Next slide, please. So let wait here. So before we move and I show you the reports which we receive from especially peripheral labs, I would like Dr. Rajinder to give us the insights about if she receives. Dr. Rajinder, are you there?
Haji. Yeah, I'm there. I don't know why
Yeah.
I'm not visible. I'm sorry,
Now
I'm
you
not
are.
visible.
Now
Okay,
you
okay.
are. Now you are.
Okay,
Yeah.
okay.
So welcome once again.
Thank you.
Dr. Rajinder, we all come across patients who present to us after having excision of breast lump done elsewhere.
Absolutely.
So what are the problems which you see in those reports? Majority of the reports, are they all satisfactory, or do you still need a lot of information? The information which you need to take decision is not there. So what are those problems which you face when the patient comes with excision biopsy?
Thank you, Dr. Vaishali, for this very, very pertinent question, because the reports which we get from periphery are usually incomplete. Most of these reports, sometimes they do mention that there is some carcinoma seen, some adenocarcinoma of the breast, but sometimes they do not mention the size of the tumor, which side it is, and what are the other markers, what are the other steps which we have seen very nicely elaborated by our pathologist friend. What should be the ideal requirements of a biopsy report, the type of tumor, the grade of tumor, the size of the breast lump which it has been excised, what are the margins, whether they are positive, negative, because sometimes the specimen is also not oriented. They will just label it as a margin is closed. We don't know which margin is closed. Then about LVI, presence of DCIS and other IHC markers. So we needed full detail if it is a proper lumpectomy specimen which has been excised.
Yeah, thanks, Dr. Rajinder, for bringing out those important, concerns. Dr. Kuldeep, is there anything
Yes, ma'am.
else which you are looking for and is not there in the pathology report? Is there anything specific which you need to take a decision about adjuvant radiation, especially if the patient has undergone conservation surgery elsewhere?
Yes, unfortunately, for radiation oncologist, it is very difficult because we generally come into the picture generally in the later part. During by that time, many times the reports are lost or they are not preserved, and because our treatment is basically topography based. It is based on the anatomy and landmarks, which are not there at present. So for us, for all three of us, like I think the radiation oncologist is the one who needs maximum information, like the margin status, orientation, the size, location, because we have to mark the boost. So we are at the most receiving end in the scenarios when reports are not available. Because for surgeons, generally tumor is there. For medical oncologists, it doesn't matter that much topographically. But for us, each and every aspect is very, very important. So if we can make the things more idealistic, I think the radiation oncologist will be the one who will be most happy.
Right. So thank you, Dr. Kuldeep. Dr. Annie, has it been your practice to review all the reports which have been done by, the reporting has been done by a lab which is not your own lab? So do you routinely get all the specimens reviewed in your
Yes,
lab?
generally, if it is a peripheral center that the patient is coming in, and especially when the receptor status is unknown and or it is not clear, sometimes they just mention positive. We do not know how much positive. We all know Aldred score is very important for us in terms of how much positivity is there, and also in terms of HER2 status, whether it was 1 plus, 2 plus. In today's era, it is very important for us, and in 2 plus, we have to do FISH. So these things matter a lot. What was the lymph node status? Many a times patients just come in sometimes just with an FNAC and they would have done the excision, and we do not know what was the status. And then we are in a fix. So we ask them to get back the specimen and actually check what it was there. So this is some things which we generally recheck the receptor status when the patients come in from a peripheral center when the reporting is not adequate. But if it is
Right.
an SQ lab, generally we do not. But patients that come to a hospital come from periphery, so we generally check all of them.
Right. Thank you. Thank you. So, Sunidhi, next slide, please. So these are some of the reports which you all have come across. So there is even the surgeons are also at fault. They do not orient the specimen. They do not mention. They are very lazy in filling the forms. Dr. Neha has actually pointed out what are the critical things which are needed for the pathologist to give a good report. So many a times the surgeons are also not giving adequate information for the pathologist. So here, as you can see, the biopsy is mentioned, but there is no mention of what type of biopsy, what is the focality, whether it is right, left, nothing has been mentioned. There is no history. And as a result, it is an inadequate report. Next slide, please. Again, here we can see that the same thing, because of this information which was lacking, the pathologist has not mentioned the size of the tumor, which is very, very important for the clinicians to take a decision. Next slide. Here again, the gross findings mention that the tissue which was submitted measures 3 into 2 into 1 centimeter. However, we do not know what was the exact size of the tumor. So all these informations are very important, whether we need any adjuvant chemotherapy, whether the patient needs any further revision surgery, all of that is very important. And sometimes we, scratch our heads as to what to do next. Next slide, please. Again, a similar kind of here, definitely the grade and everything has been nicely mentioned. I don't know what was wrong here. Sorry. The tumor was not probably oriented, and as a result, the report says that the tumor reaches the inked and cauterized closest margin, but the surgeon doesn't know which margin was that, whether it was a superior, inferior, lateral, medial, what. So all of these are the reports which lack some vital information. And as Dr. Garima, Dr. Neha, and Dr. Gaurav have mentioned, that it is very, very important for the surgeon and the pathologist to be on the same platform. And the radiology report, the radiological findings are also should be provided to the pathologist, so that optimum pathology report can be released. Next slide, please. Next slide. Next. Right. Now, this is infiltrating lobular carcinoma, this report. Again, the grade is not mentioned. So, all of that is, we get to see such reports. I think next, please. So, size of the tumor, grade, everything is missing in this report. Next. Now, this is a very important problem which we come across, that the side of this disease, whether it is right or left, is not mentioned. Then the tumor is actually taken out in piecemeal manner. And as a result, the pathologists are at a loss to report the actual tumor size. And the receiving end is the patient. Patient does not get adequate treatment because of all of that. So all of these practices should be actually refrained from. We should provide appropriate information. We should perform core needle biopsy whenever there is a clinical or radiological suspicion, rather than doing a excision biopsy. So, Dr. Prekshi, now I will hand over to you for further discussion.
Sure.
Sure.
So good evening, everyone.
Can I make a comment, Vaishali?
Yes.
Hello.
Yes, sir, you are audible.
You see, the biggest problem is in our country, patient goes with a lump in the breast. No investigation, no ultrasound, straightforward excision biopsy. We do not know the size, we do not know and of course, the biopsy report that Vaishali has shown. That is the biggest problem. Most of the patients from periphery comes with the excision biopsy, no mention of the size of the tumor, no mention of the specimen of the tumor. Even if you bring the blocks and slides, it's very difficult to assess the margins, etc. Second thing, what we have practiced at my center, we are always sending a imaging report with the pathology form to the pathologist. Whether it is a pre-NSCT, whether it is a post-NSCT, or post-NSCT, we are sending both the forms. Pre-NSCT mammogram or PET scan, and post-NSCT a mammogram or PET scan or MRI, whatever has been done. That gives a reasonable information to pathologist where to look for, how much to look for. I think that is very, very important today.
Exactly, sir. So I would also like to say that most of the questions have been very well covered by all the speakers, and we'll just reiterate all these important points. So next slide, please, Sunidhi. Next, please. So yes, we have discussed that many times, what all information is lacking in the reports from the peripheral labs. Next, please. Next. Yeah. So yes, sitting in a tertiary care center and giving all these information, but this question is for the pathologist, that what should be the ideal sequence of reporting. But many a times we see that from all these reports which have been done elsewhere, there is quite like impression is written first, or something is, so there is a proper order in which the findings are to be enumerated. Dr. Neha, would you like to answer this question? Just a very basic question. Dr. Neha, are you there?
Yes, I'm there. So when you talk about the sequence of reporting, like Dr. Gaurav has mentioned in reporting parameters, we have proper guidelines, CAP guidelines or RC Path guidelines, where they give you certain set of parameters and the sequence that follows. So if everybody follows the same thing, then all the reports would be more identical rather than being dissimilar. So you cover all the points that are there as per the guidelines, which usually starts from the type of procedure, the laterality, the tumor site, tumor focality, type, grade, margin status. There are a lot of parameters which should be all covered in the same sequence, depending on which guidelines you're using, CAP protocol or RC Path or any other which is a proper documented guideline. And then in the end, you should have a final impression which says it all. in the sense that in one look the surgeon or the clinician is able to understand the most important things, that okay, the margin is free, the tumor is grade 2, the nodes are positive or not, what is the TNM stage, what is the RCB score or the class. So it is like just 4 or 5 points in the end would really help. Otherwise, of course, you have already mentioned it in all the parameters. That can be also taken by some people, but if you just give a final impression, that really helps the clinician to have a quick look and understand what the status of the specimen is.
Exactly. Next thing is, if there is pure DCIS, what all information do you need? This question I would first like to ask Dr. Saggu. Ma'am, for pure DCIS, what are the points which you look for?
We need to know what is the grade of DCIS, a low grade, intermediate grade, high grade. What is the size of DCIS? Is it multifocal? Is it just a solitary one at one area? Is it multifocal, multicentric? How many quadrants are involved? And obviously, that will help us decide. As a surgeon, obviously, it will help me decide the type of surgery I want to do. And also, if it is low grade, probably if the margin is little bit closer or it is focal, probably it will be covered up by Dr. Kuldeep Sharma, a good radiation oncologist, and Dr. Prekshi. But if it is intermediate high grade, we need to have a margin of at least they say 2 mm. That is a adequate margin for to be called as negative margin for DCIS.
Yeah. And at the same time, I would also like to have your comment regarding extensive intraductal component. So,
Yeah.
what do you think it makes a change if it is present?
Extensive intraductal component, probably it means there is DCIS, which comprises more than 25% of the tumor area, and it is also beyond the tumor area, and it is actually considered as a prognostic factor, which means a presence of EIC. There is a higher risk of local recurrence, as well as higher risk of margins coming out to be positive. So, but most of our reports are not are not reported. EIC is not reported, but it should be reported. It should be, I think, in the sequence of reporting, it should come as one of the parameters, which should tell us what, because we have to decide on BCS margins. If EIC is coming positive, then there is a higher risk of local recurrence in such cases, and we need to go wider. But how much wider? Still, it is
Not explored till.
not explored yet. Yeah.
Dr. Kuldeep, I would like to extend the same question to you also. What does this mean, EIC, and for DCIS also, what these parameters change your radiation planning? And do you need to give some extra dose or in the form of boost if EIC is present? So what all things do you consider?
Yeah, as ma'am has said that if EIC is present, that shows more aggressiveness and the propensity of the tumor to spread laterally, maybe. So in these cases, our boost dose is the one that is affected mainly. So if there is EIC present, then I would like to have my boost to a bit wider volume, so that I make sure that the margins are adequately covered. And in that scenario, I would like to give a bit higher dose towards boost, maybe from 10 to 15 gray. So in that, I would like to go towards the higher side. So that is the implication on radiation doses and radiation fields.
Okay. Then to the pathologist, Dr. Gaurav, what is your comment on what do you say about how important EIC is regarding the aggressiveness and all that thing? What do you want to say about it?
I think already answered that if it is high grade, definitely that is prognostically important, and if it is close to margin, margins should be more than 2 mm. Then that is the importance of EIC. Yes, in post NACT specimens, EIC generally because they don't respond to chemotherapy. So probably I don't know why this is still ring bells in my mind that if there is a residual DCIS, how can these global bodies label it as a pathological complete response when there is no invasive residual cancer and only DCIS is left? Though DCIS is very less chances, if it is low grade, very less chances of progressing it to invasive carcinoma. But still, maybe because the specimen has now been removed and probably that is the reason they are considering it as pathological complete response. But yes, if it is extensive DCAIS only and there is no invasive component, of course, if it is high grade, then it should be dealt with surgical resection with having appropriate margins and probably extensive DCIS usually has a high grade component. And the most important thing, as far as pathology is concerned, I think extensive sampling in such specimens which are showing extensive DCIS, extensive sampling is very important because there might be some focus of microinvasion in those specimens. So the specimens should be extensively processed and to look for microinvasion and help from IHC staining should also be taken, like staining for myoepithelial markers like P63 or SMMHC. These markers help in identifying those areas which lack myoepithelial cells and to pick up those small foci of microinvasion easily. So I think that is my take for how to go about these extensive intraductal component cases. Specimens should be adequately grossed, extensively grossed, and extensive search for microinvasive component should be done with the help of immunohistochemistry.
Okay, great. Dr. Neha, next question I would like to ask you that if suppose there is a mixed invasive carcinoma, whether it is IDC and lobular or neuroendocrine, so is there any threshold below which you won't consider it, or you are just mentioning it with the percentage, or do you find any difficulty whenever there is mixed invasive carcinoma in diagnosing it? So please, your comments.
Yeah, so when it comes to mixed tumors, usually you find a ITC component which is mixed with another special subtype, like mucinous lobular or some other type. So if this special subtype is less than 10% overall, when you've seen all your sections, then it is still considered as an ITC, IPC NST. But if the percentage of the special subtype is more than 90%, then it is labeled as whatever the special subtype is. Then you don't call it IPC NST with a subtype, you call it simply lobular carcinoma or mucinous carcinoma. Now, when this special subtype percentage is between 10 to 90%, then you will give it as a combination that it is a mixed tumor containing a ductal component and let's say 20% of lobular or 50% of mucinous component. So then you give a mixed tumor that this is IDC along with a special subtype. Important to mention the percentage of the tumor. And of course, if it is between 10 to 90%, then only you give it as a mixed tumor. Otherwise, below 10 and above 90, you have to label it accordingly, whatever type is dominant.
Right. Next, please, Sunidhi. Yeah, so this is basically for the students. So when we say it's T4B pathologically, Dr. Gaurav, what does this mean? Clinical involvement of skin, does it differ from the pathological assessment? So what do you like to say about it?
T4B is involving adjoining skin and nearby organs. So basically, can you repeat the question?
See, many times it happens that clinically the skin seems to be involved, but the pathologist do not say. Like I was asking about whether epidermis or dermis. So that point I wanted to clarify.
Okay, so basically the epidermis has to be involved to call T4B. Otherwise, if it is reaching up to the dermis and it is not involving the epidermis, then we refrain from calling it T4B. So epidermis has to be involved. Sometimes the epidermis is so stretched out, the skin is so stretched out that it does not, but the skin is intact. The epidermis is intact, but it is thinned out. So until it is ulcerated or the tumor cells are seated within the epidermis, we don't call it T4B.
Right, right. So that's what this point we wanted to clarify, that for the students, like if the epidermis is involved, then only you have to say that it is
Yes.
T4B. Otherwise, even if clinically the skin seems to be involved, it is not T4B until epidermis is involved.
Yes.
So then a word about metaplastic carcinoma versus sarcoma. Dr. Neha?
Anji.
So do you find some difficulty in differentiating metaplastic carcinoma from sarcoma, and please comment from your side on the pathological features of both.
Metaplastic carcinomas can always be difficult to differentiate from sarcomas. Not just sarcomas, metaplastic carcinomas, there are different subtypes, right? So they can mimic mesenchymal lesions, whether benign or malignant, low grade or high grade. For that, you of course look at the morphology also. Sometimes you may, apart from, let's say it's a spindle cell morphology, it's not the usual ductal ovulomucinous morphology you're getting. It's a spindle cell morphology. You don't know whether it is a low grade mesenchymal lesion or it is a metaplastic carcinoma. So we can try to look for surrounding areas. If there is any DCIS present around the tumor in close vicinity, then it is likely to be a metaplastic CA over a mesenchymal lesion. And many times you don't find anything, so it can be very difficult. And then of course you need to do some IHC markers, which also always may not be clear cut. There can be a lot of overlap. But generally, metaplastic carcinomas can show positivity for high molecular weight CKs. So you can do CK14, CK5/6, high molecular weight, CK 34 beta 12. You can do P63, which comes positive in metaplastic CAs. And then depending on the morphology, you have to make a differential in the mesenchymal lesion, low grade, high grade sarcoma, whichever you are considering as a differential. And based on what differential you're considering, you will think of IHC markers of that particular tumor to differentiate. But yes, many a times it is extremely difficult to differentiate between the two on core biopsies. And if you're lucky, then of course you can always come down to a conclusion. These tumors are ERP or HER2 negative, so again that is also out. You can't use them to differentiate. But small things like if you are lucky and if your IHC is coming positive for metaplastic, then of course you can give it. Or if, like I said, you find some DCIs or epithelial component around it, then again you can call it metaplastic over sarcoma. And of course, metaplastic carcinoma will be more common than a sarcoma in the breast. So you have to obviously go by common things, though you can always get a very rare tumor and that can be there, but still you have to start from the commonest to the rarest.
Right. Dr. Annie, word from your side regarding the prognosis of metaplastic and their response to the systemic therapy?
If we have to compare that with the invasive ductal component that we generally find in breast, metaplastic generally don't do that well to chemotherapy, and their survival rates are also lesser compared to ductal. So this, and also the type of chemotherapy that we have to use in metaplastic and a sarcoma wise, it differs actually. So it's very important for us to know what type exact histology is present, because prognostication accordingly will be depending on that.
May I share some information regarding this metaplastic carcinoma from sarcoma case? Recently, I came across a case labeled as metaplastic carcinoma from outside in a core biopsy, and but the patient is not responding to chemotherapy. And we got the resection specimen. And what to our surprise, when we saw the resection specimen, we didn't think it as metaplastic carcinoma. But what we saw is, can you see my screen? The specimen on the screen?
Your slides are visible. Yeah. It is there.
Yes. So if you see this slice, you can see the margins are very well circumscribed. It is pushing the skin and it is reaching close to the posterior resection margin. But the most important thing is central cystic kind of degeneration. And these are papillary frond-like structures and edematous areas. So this metaplastic carcinoma, actually we diagnosed it as a malignant phyllodes. So this is again a very close differential for metaplastic carcinoma. On what basis we differentiated it from metaplastic carcinoma was the presence of benign ducts which were there in the center of the lesion. So the presence of because the malignant phyllodes is a tumor of spindle cells of the tumor of intralobular stroma. So the stroma is malignant, but we could see some benign ducts within the tumor and those papillary fronds which are very characteristic of malignant phyllodes. And to our surprise, the immunohistochemistry was very much like in between the metaplastic carcinoma and malignant phyllodes. Malignant phyllodes are generally CD34 negative. CD34 is positive in benign phyllodes. So CD34 may not be the always helpful immunohistochemistry when we are dealing with malignant phyllodes. So we have to read the immunohistochemistry findings also cautiously based on the morphology and in the context of rare scenarios as well. So malignant phyllodes may not show exact immunohistochemistry which is seen in benign phyllodes, and malignant phyllodes can show some expressions which are seen in metaplastic carcinomas. Like malignant phyllodes can those undifferentiated stromal cells can start showing P63 expression. P63 is a marker of stemness, and which is positive in metaplastic carcinoma can also be positive in malignant phyllodes. And similarly, pan-CK expression can be seen in malignant phylloid stromal cells. So it has to be seen on the background of morphology, on the background of gross description, and on the clinical context also. So metaplastic carcinoma can also mimic a malignant phyllodes as well.
Yes, actually, we also came across a similar case, and that's why this question has been capped. So both these questions have been already dealt in the previous talks. Next slide, please, Sunidhi. Next, please. Next. So this is actually we are very short of time, so cannot discuss all these things in detail. Next, please. This is post NACT histopathology report, and this is actually covered by Dr. Neha as well as Dr. Gaurav in their talks. Now I would like to hand over to Dr. Safalta for the remaining session.
Next slide, please. So, next slide, please. Next slide. So, to Dr. Sagu, I just wanted to ask if there is any difference in the margin width when you after NACT when you decide upfrontly as on post NACT.
Yeah, hi. Actually, in breast conserving surgery, our main motive is to ensure negative margins. But there is no requirement of the question is the margin assessment, whether they are different after NACT. I think there is no difference between the margin status if the surgery is done after NACT or it is a primary surgery. Most of the guidelines they say that no incon tumor is considered the standard, but this is equal both for with or without NACT, and there is no need to excise like 2 mm, 5 mm, or 1 centimeter. I think no incon tumor, or I usually take 1 mm margin sufficient even before and after NACT. And for DCIS, as I already said, for pure DCIS, the margin should be more than 2 mm.
Okay. Next question has already been covered. I wanted to ask Dr. Gaurav, you said that yes, DCIS, presence of DCIS post NACT is not considered as a residual tumor, but I would like to ask Dr. Annie. So, do you think presence of DCIS should be considered as residual tumor or it should not be considered as a residual tumor clinically to take a treatment decision? Any Baba? Any Ba?
Sorry, I was not, yeah. So, presence of DCIS, generally we take it as residual disease, because only the thing is, in certain situations, like in HER2 positive, when we give a NACT and there is DCIS component present in the post chemo specimen, we always have to think about whether we have to change the adjuvant therapy or no. But this is a debatable topic. In Catherine's study, they have taken DCIS patients, but very few patients have been taken. So our treatment decision, in certain situation, we have to take it as a full component to say that it is a residual disease, but we take it as residual disease here.
Yes, that's what, because DCIS, actually, we don't try to push patients to change of the treatment if there is like tolerance can be a issue for the patient when we change the treatment. So if at all a young patient, we would suggest it, but if a elderly patient, then in that case, probably we'll continue the same treatment which was there. Next slide, please.
Can I ask one question regarding this?
Yes, sure.
Yeah. So, does this question come that DCIS is not considered as residual tumor? Does it come from the fact that this component is generally not considered responsive to chemotherapy? So,
Yes.
is that the reason they neglect or they ignore its presence to be considered as residual disease?
Can be a possibility, because when you go to the literature, they say likely it is not a chemoresponsive part, so that's why it is not considered as a residual disease, and it can be taken care by the rest of the treatment. Like you give radiation, you give hormone therapy if it is ER positive baseline. So that's how it is considered. But then, like Catherine study, that is the study because of which we are discussing about this DCIS. That is in that study, if the DCIS was there, then in that case, the treatment strategies to be changed in the maintenance therapy. So that makes it very important for us. Yes. So we have already covered RCB part. One important part is uh, that is rest. You have already discussed how the post NECT is. But what about the decision about the regional node involvement post NECT? So, how you judge those nodes, how the response assessment of those nodes are done? Dr. Gaurav. Dr. Gaurav.
Yes, Dr. Spalta. Yes.
So, when you document the reporting of post NACT specimen, then in that case, how do you report this regional node involvement?
Regional node involvement, yes, we have to we have to measure the size of the residual tumor focus, and that is important in calculating the residual cancer burden. And again, we don't include the fibrotic area, which is secondary to response to treatment. We have to identify only the residual invasive tumor size and mention it in the residual cancer burden calculator provided by Anderson Institute. So, and if we have to identify, sometimes we may take help of IHC to identify the tumor cells, isolated tumor cells, but generally they are quite easily visible with associated desmoplastic response. And yes, the pathologist should also be able to differentiate the fibrotic response, which is secondary to treatment, or the fibrotic response which is present before chemotherapy. Like the tumor also incites some desmoplastic response. So the desmoplastic response, which is secondary to tumor, is included in the size of the tumor, but the fibrosis, which is secondary to chemotherapeutic response, should not be included in the size of the tumor. So that is how the tumor size should be calculated in the lymph node. Same way which we do in the breast resection specimen, the same criteria is applied for calculating the size on the lymph nodes as well.
I would like to ask here a question to Dr. Kuldeep. Sir, how does you decide regarding the regional nodes? Would you like to irradiate them or not consider them after NACT? So what are the deciding criteria? Which all stations you want to include, which all lymph node regions you want to include? So will you
Okay.
like to, yeah.
Yeah, so as a general principle, when we give radiation, so most of our doses and most of our criterias, they generally tend to depend upon the initial presentation. So, of course, if the nodes initially they were involved, they were grossly involved, and they were multiple, the supraclavicular region will be included. And if after NACT, if you come to know that still there are residual nodes, then of course the patient stands at a higher risk. So in that case, you make sure that you irradiate all the volumes properly, and you do not leave any regional part, nodal region untreated or undertreated. But it doesn't have a direct implication on the criterias, because our criterias depend on the initial findings.
Right. So
Dr.
if suppose there was an IMC present, internal
Okay, yeah.
memory chain, there was a node present, and after NACT it is resolved completely. So and it is a left-sided breast cancer. So would you like to irradiate IMC region in such a
Yeah,
scenario?
yeah. Yeah. If we have some FNAC or something which is generally not available, if we have that available, and if radiologically we think that it was actually a positive node, I would tend to include the chain in my radiation portals.
And what dose, mean hard dose, do you follow in such cases?
Yeah, of course, if we are going for 40 gray, then the hard dose will increase a bit. Like it will be like on an average, it will increase by 2 gray or so. But I think that is worth giving if the gross nodes were present at the presentation. So there is no clear guidelines, but personally, I will take them in. If not the entire chain, then at least the high risk regions of the second, third, and fourth intercostal space.
Right. Thank you. Dr. Safalta, over to you.
Next slide, please. So, this topic we have already covered, like post NACT, in especially in the TNBC patients, we should do as ERPR testing again. Next slide, please. So, like in the breast, and it was documented. Next slide, please. That almost a good number of patients they who are triple negative initially they may have their CRPR positivity, and with treatment they who are not responding well, then in that case we should do this ERPR testing and HER2 testing. Next slide, please. I would like to ask the pathologist, I would like to ask Dr. Neha. So this is a Maggie scoring system, and it is very important for us to, like, this is an important platform because this is one of the cheapest way to document the oncotype DX when the patients who are not able to afford oncotype DX. In that case, this is a Maggie scoring system. Here it is written ER, H score, PR, H score. So what is this H score?
Actually, I'm also not sure. Um, because we calculate ER based on intensity and proportion.
Hmm.
So I'm honestly not sure about the H score.
Dr. Gaurav, do you know about it?
H score is, am I audible?
Yes, you are
Yes,
audible.
yes.
H score is basically intensity and percentage. Yeah, it is calculated on the basis of intensity and distribution. So probably if percentage of tumor cells is weak, if we suppose we are getting around 10% of tumor cells are showing weak expression. So we multiply it by 1. Moderate staining, if we are seeing around 20%, we multiply it by 2. And if there is a strong expression, like suppose if we are getting 20% of tumor cells showing strong expression, we multiply it by 3. And we sum up all these expressions, like percentage of tumor cells showing weak expression, moderate expression, and strong expression. So this gives us H score. So probably that is the way we calculate the H score, and we can give it, but it is as I said in the beginning, that reports can be clinician driven as well. So if you ask your pathologist, they can tell you this H score based on these findings, based on this what is ERP or HER2 is available. So I think we can
Okay.
calculate this H score easily. But yes, definitely it will add on doing some more exercise while reporting the cases
So
routinely.
how much time it will take for reporting an H score?
Not much, maybe around 10 minutes more per
Okay,
case.
okay.
Yes, yes.
That's what I'm thinking of, how much to burden my pathologist. So next slide,
Mm.
please. So immunohistochemistry is HER2. HER2, is there any specific platform to report HER2 IHCs in breast carcinomas? So like,
Platform, like it should be done on a, Ventana platform ideally,
okay.
or any platform can be done. Like even if it is manually it is done. It should be the results should be validated prior. All the immunohistochemistry results should be performed on a validated platform. Even if it is done manually or on some automated platform, the results should be prior validated. First of all, is this validation. Secondly, the HER2 IHC interpretation should be done in the presence of external control slides, external control tissue. And the external control block should be composed of a composite tissue, which should include the 1 plus expression, 2 plus expression, and 3 plus expression, so that you can compare it with your test. So ideally, this is the ideal situation. What I am telling you, at places you don't get the resection specimen of 2 plus specimen, because you make your external control blocks from generally from resection specimen. You cannot use core tissue biopsies for making your control specimens, right? So
Okay.
ideally, in HER2, in interpreting the HER2 results, every slide should have a section from external control, which should include 1 plus expression, 2 plus expression, and 3 plus expression for comparison, for comparing the test results. So that is the way to perform HER2 in ideal scenario.
Okay. So next slide, please. That's what I want to know. Like there are many even the experienced pathologists. The reporting of experienced pathologists, even there was a concordance of only 26% in 0 and 1 plus. So it has become very difficult. Being like TDXD and many ADCs have come up, and we are now willing to get those specific reports of 0 and 1 plus. 2 plus, 3
Yes.
plus reports are concordance was only 58%. So do you
Mhm.
think that even in the department also two pathologists should report if it is HER2 positive in testing?
Yes, definitely, because even just yesterday, my senior resident thought that this tumor is showing 3 plus expression, but
Mm.
actually it was not a 3 plus expression, it was 2 plus expression. It was just a small clone of tumor cells which was showing strong and intense expression. So for
Mhm.
calling a 3 plus expression, if you have to change your lens from low power to high power, that means it is not a 3 plus expression.
Hmm.
So a 3 plus expression should be very chunky, should be very crisp, it should be very clear, and it should be easily visible on a low power examination, on a low power lens. So, and definitely, if there is some small clone which is heterogeneously expressing strong expression, it should be called as 2 plus only. And yes, consensus amongst two pathologists within the department should always be there while labeling HER2 staining, especially when dealing with 1 plus and 2 plus staining patterns.
Okay. Next slide, please. Next slide. Next slide, please. So here, like we have seen concordance of the three pathologists. Do you think we should use, Dr. Neha, please answer this question. Do you think we should use some AI based to for the documentation for the reporting of HER2 expression? Dr. Neha? Dr. Neha, are you there? Dr. Gaurav, can you answer this question? Our pathologists have left.
No, I'm still there.
Mhm.
Actually, my screen went off. Yes, so I think definitely AI will definitely help. But first we have to teach our AI also, and
Mm.
we should have the availability of these AI platform. And most important, we need to have the scanners. The AI is still, I think, it's very difficult to get on our desks. Because one first we have to need first we need to have scanners, and then we need to teach the AI models, and then we have to those softwares so that we can take the images and ask AI to tell the results. Definitely AI helps, and AI assistance is definitely more will would be, I think, more helpful rather than handing over the entire job to AI doing her two results.
Yes, definitely. So AI cannot replace us, it can only help us to make the
Yes.
decisions. Yeah. Next slide, please. And with that, I would like to thank you, all the panelists, for this wonderful discussion. And I would like to hand over to Dr. Rajiv for the vote of thanks.
Thank you, Safalta. I think we had a wonderful session today, as usual. Uh, uh, since already we have overshooted the time, I won't take much time. I would like to thank my esteemed faculty. All of them have done a wonderful job today. The delegates, without delegates, the no seminar can be successful. So my sincere thanks to delegates and the organizing uh, company, that is Mighty Due. They have done a flawless job today. But before I conclude, I will like to mention my younger colleagues who are doing very hard work throughout the month to make this uh, seminar a success. Vaishali, of course, is a guide, but Pekshi and Safalta, they have become the spine of these seminars. They are doing day in and day out a very good effort. Pekshi always is on the toes and keeps everybody else on the toes also. So, with that, I think before I conclude, I wish you all a very, very happy upcoming Diwali, and thank you and good night.
Thank you, sir. Thank you.
Thank you.
Thank you, everyone. Good night.
Thank you.